right, welcome to the CNS Journal podcast. This is the February edition, 2023. My name is Rafael Vega. I'm currently at the Beth Israel Deaconess Medical Center as the director of the Brain Tumor Center here. And I'm very happy to present Dr. Paul Gardner, who is our guest speaker, as well as our faculty guest, Dr. Gab Zada, and our CNS podcast fellow, Hayden Hoffman from SUNY Upstate. So we'll go ahead and get into the topic. It's going to be the evolution of endoscopic endonasal approach for olfactory groove meningiomas. And by all means, Dr. Gardner, please introduce yourself to the group.
Thank you. It's Paul Gardner. I'm the co-director, neurosurgical director of skull-base surgery at University of Pittsburgh Medical Center, and also vice chair of neurosurgery for surgical services. We obviously have very much pushed endoscopic endonasal boundaries, and I think that's part of the part of what this manuscript was about, is trying to study and understand our own outcomes.
Wonderful. Thank you so much. And again, we have Gab Zada from USC. Would you like to introduce yourself for the group?
Sure. Hi, everyone. Gab Zada from University of Southern California in Los Angeles. I'm the surgical director of our Brain Tumor Center, and I also co-direct the Skull-Base Surgery Center here. Thanks for having me.
Yeah, welcome. Thank you. And then, of course, Hayden Hoffman, please, would you introduce yourself too?
Yes, thank you. My name's Hayden. I'm a neurosurgery resident at SUNY Upstate in Syracuse.
All right, thank you. So we'll go ahead and get started. Paul, would you like to kind of just discuss the paper a little bit more and talk a little bit about the results, and we'll start in getting into it.
Absolutely. So this is there's a lot of controversy. Probably one of the most controversial topics with endonasal surgery is these olfactory groove meningiomas. And most of the literature out there, for comparing endonasal surgery is relatively older series, and it's probably been the one area that hasn't really caught on. So I wanted to take a look at our own modern series just to see, where we stand. And so this was 75 different patients that were looked at over a relatively long period of time. And we sort of looked at them in three different quartiles. So this was between January 2003 and June of 2020. So more than one surgeon, but at one institution with a very similar technique. And we just wanted to look at the outcomes and see if they changed over time. Did we get better at this? Was this something that we learned about? And if so, how and what did we learn? And so this was 75 tumors conveniently. And we turns out when we broke them into thirds by time, and actually, we were doing about 25 tumors each of these time periods. So so not a very common approach that we would use, and certainly not the only approach we use for olfactory groove meningiomas, but largely, at least my philosophy, is to try to approach them this way. And when looking at this, we're able to get not just a quote gross total resection, but a Simpson grade 1 resection of olfactory groove meningioma 64% of the time, so almost 2/3 of the time. Interestingly enough, one of the big negatives of endonasal surgery for these tumors is the guaranteed loss of olfaction, unless it's these rare unilateral tumors where you have a chance. Whereas craniotomy gives you some chance of saving olfaction, although probably most series show that's well under 50%. But in our series, only about 25% of patients actually had intact olfaction. Almost over 50%, it was completely absent, and the rest, it was altered or significantly diminished. And so, this sort of, I think, is important for that particular discussion, although that remains an important part of it. Now, like I said, these three tiers were 6 years each, and 25 patients fell into each one of those 6 years, which kind of makes for a convenient comparison. And we could see actual markers of change in our surgical technique. For example, when we look at the contemporary group, this last third, there was no staging in that contemporary group, whereas early on in our experience, we staged quite frequently, and this perhaps was due to inexperience or getting better at it, or understanding which tumors we couldn't remove safely. We also increasingly used a draft 3, and what that is, for neurosurgeons who aren't necessarily familiar with that, but it's basically a very wide frontal sinus opening endonasally from below, and that allows you to see the entire frontal sinus, connect both sides, And that allowed us to have a very good landmark for the frontal or the most anterior part of the tumor. And that's probably why we did it more often. And then finally, perhaps the most significant difference was in reconstruction, where we now use a multi-layer reconstruction, which consists of an inlay, an intradural inlay of a collagen matrix like Duramatrix, for example, and then an onlay of a fascia lata, a large piece of fascia lata that's then laid onto the graft, laid onto the epidural space, tucked in the epidural space, and then finally a vascularized nasal septal flap that's placed on top of that. Of course, the nasal septal flap was not even around for the first a couple of years of this series, but the multi-layer reconstruction is probably the biggest difference that led to a decrease then in spinal fluid leak rate, which dropped down to about 8% in most recent years and was really quite high in early years. And that was significant. There was really no change in some important outcomes, things like permanent visual compromise. We didn't have any cases where that occurred. But perhaps another marker of microsurgical technique that we found is that the other thing that was different over time is that the postoperative encephalomalacia, or the brain loss, the frontal lobe malacia that was left after the tumor, decreased over time. And remember, these are the same size tumors across time, so the tumor size was not appreciably different across these sets. And then also, the time that the brain edema resolved was dramatically faster in the contemporary group. So these are markers that perhaps we're getting better at our surgery over time, and hopefully having, therefore, less impact on the frontal lobe. But you know, as many papers do show, and many of our papers show, there's a learning curve with approaching these more complicated skull-based tumors, and I think that's one of the other take-home messages from this paper.
Yeah, thank you so much for that overview, and congratulations to you and the rest of your authors for that paper, because I think it's going to be a nice one for everybody to look at. We can go ahead and start with Gab Zada, if you'd like to just go ahead and ask any questions and start the conversation.
Yeah, sure. Thank you. So I really enjoyed reading this paper. For me, the main highlights were, number one, that UPMC has really pushed the envelope with their vast experience over several decades. And so we get to learn from their experience. And there are a lot of learning curve type studies out there, but what I really like about this one is not only do we see the improvements you'd expect in things like spinal fluid leakage rates, et cetera, but that they really describe how their technique has evolved, and also the tumors that they've gone after, and the selection of cases has evolved. And that's, I think, for me, what I really enjoyed reading so much. And I got to visit Pittsburgh last month for a skull-based course and watch Dr. Gardner perform a live surgery on olfactory groove meningioma and see exactly how amazing they are at performing these approaches. And for one, not only did I learn a lot, but I really commend them on their dedication, number one, to reducing frontal lobe edema. And I think that concept is absolutely critical. And number two, their dedication to a Simpson grade 1 resection with bony involvement. And so I think, we're really benefactors of that. But I want to pose a couple questions to Dr. Gardner based on the series. And the first question would be, you've done such a good job describing the techniques and some of the outcomes, et cetera, but how do you think overall case selection has evolved at UPMC over the same time period? And as you know, Paul, I still do a fair amount of craniotomies for anterior skull-based meningiomas. I really like supraorbital keyhole approaches and occasionally lateral terional or OZ approaches, rarely a bifrontal these days, unless it's really a giant tumor with lateral extension. But maybe you can talk about how that whole practice pattern has evolved at UPMC.
Sure. I mean, one of the things that we always try to do with this data is to learn from it. And we published a paper not too long ago, actually, I believe with the same author, Pierre Champagne, who was fantastic, spent a year with us and really did, as a superb surgeon, did some great work while he was there. But looking at where we had residual left behind on these tumors, and that residual is in very specific areas, and and I think we learned somewhat where we do well with removing the tumor and where we don't. And so some of these more spread out kind of sessile tumors that might go over the orbital apex, for example, I still might remove those endonasally, but that's pushed me a little bit perhaps to doing an open approach. And what's interesting is that, there's no size differentiation on these tumors in this case series, but I do think there's probably some bias if I have a large tumor that's really billowing out, there is still probably a bias if it's extending and truly has a dural attachment, then maybe to do that through a craniotomy. So there may be a subtle bias there. In addition, obviously average tumor size depends on small versus large tumor. So I think we've gotten a little more selective in our cases. But as you see, based on the number done over that time period, I don't think there's a huge difference in the cases that we're choosing to do endonasal. I think the concept still remains. I think we've learned how to do some of those more challenging cases better. I will freely admit that there are probably two or three cases in that first part where we maybe now would do it through a craniotomy. But in general, I don't think there's a huge differentiation there.
Yeah, that says a lot. And I think a couple things I took away. It seemed like you were able to chase more tumors over time that extended more laterally over the orbit. And one thing I really picked up from you, Paul, is how you focus on taking off the lamina papyrica and really the lateral components of the anterior skull base, and that gets you over to the midline of the orbit. I mean, I thought that was a really nice technique that you guys have worked on there.
Yeah, I think probably one of the other things, and this is important to say, that you, I think, probably saw is that these are painfully difficult surgeries. This is a challenging surgery, and so that's not a. I think that's part of where the learning curve is reflected in this, and part of why this hasn't really picked up. You really do have to sort of torture yourself a bit to make it through these cases. I apologize too. I misquoted. It was Pierre Champagne who did this most recent paper, but one of our former fellows, Dr. Setti, who now I believe is still in Detroit, actually wrote the paper on looking at where we have recurrence or where we have residual, which was for me very important learning.
Yeah, and you've segued beautifully into my next question, because for me, some of the pain points around this procedure are the sinonasal issues and the reconstruction, and especially when you have a really large olfactory groove meningioma, et cetera. And so I also noticed in this paper that there was more and more maybe reliance on lumbar drainage, and some of that may have been borne out by your level 1 randomized control trial that came out of UPMC. So do you have any comments about some of those trends as well?
Sure. I mean, I think that was a significant learning point for us. There's a lot of controversy about, do you use lumbar drains, do you not? And the truth is, for pituitary tumors, you don't need them. And interestingly enough, so we did a randomized control trial that we had to stop early because it met criteria which were dramatic for leak, especially with larger anterior fossa and posterior fossa. Interestingly, it was not significant for the suprasellar tumors like the craniopharyngiomas and tubercular meningiomas, which is actually what a lot of literature is based on. So it's actually consistent with that literature, which shows that lumbar drains, a lot of people aren't using them and having success. But when you move to these more anterior defects, the CSF leak rates are dramatically different. Without a lumbar drain, you're talking about 4 or 5 times more. So this is really an area where a lumbar drain is critical and did play an important role for us over time in decreasing that leak rate. But I also think the multi-layer reconstruction, where we didn't rely just on a nasal septal flap, also was a pretty important part. And that's something, we learned from other surgeons. So watching what other surgeons do and have success with is always an important thing to learn, and never think that your technique is the best and the only way, especially if it's something that you're really not having ideal results with.
Great, thank you.
All right, thank you so much. One thing I wanted to ask from our end is, we actually had a grand rounds about this 2 weeks ago, and we were discussing this approach and what are some of the limitations that prevent people from moving towards, just like you mentioned in the paper. And one of those was, I guess, from a technical standpoint, when you're doing the resection, I know it's not really commented too much in the paper, but what about, manipulation of the blood vessels or any kind of injury? Or what about, like, how do you handle the bleeding when you're trying to really remove or cut off that blood supply,
Yeah, great question. I mean, the first point about vascular dissection is absolutely critical, and this is sort of a mantra of about the learning curve. It's a learning curve mantra, is that we really have to respect your own learning curve, and vascular endoscopic microsurgical dissection of vasculature is probably at the far end of that learning curve. And you have to be, willing and able to go through that learning curve. So if you have a tumor that doesn't encase the blood vessels, in fact, doesn't even touch them, that's pretty straightforward. Worst case scenario, you violate the PIA, for example. But if you have a tumor that's at least adherent or in contact with those vessels, now you do have to be comfortable to be able to dissect them off, and sometimes they'll come right off without problem. If the tumor is really radiographically encased, I think a lot of people are more comfortable doing that through an open approach, and that's a relative contraindication to this approach. But the truth is that with experience, you can get just as facile at doing this endonasally, but that's at the end of the learning curve. And I think it's a very, very important part of this. And for many people, having that as a limitation of the approach is appropriate. And I think it really needs to be a point of discussion and with any patient. You have to do what you're comfortable with and what you think you can apply best. And then the other point about the bleeding at the base of the skull, this is, both of these parts really take team surgery. So, you can't have a sinus surgeon just do the whole exposure and remove the bone and everything. You really have to know the anatomy. You've got to be able to selectively coagulate the ethmoidal arteries very early on, perhaps by opening the lamina propria and identifying it, where it exits the periorbita. Coagulate the whole surface, understand what the blood supply that this is, understand that the other blood supply is from the falx itself, and you want to try to understand where those vessels will be coming from. But you can't do either that, nor can you do intracranial vascular dissection without a team doing dynamic endoscopy and working with two-handed surgery. It's really critical. And that teamwork aspect often gets underappreciated. And truthfully, if I went, one of the big limitations, if I went to another hospital with a new ENT, I'd have to go through a learning curve again. I couldn't just go somewhere and do this with anyone. And so that need for true team surgery is a limitation.
Thank you so much. Hayden, by all means, please join us.
Thank you so much. Dr. Gardner, one of the reasons I really enjoyed this paper is the number of outcomes you covered, everything from, obviously CSF leak to time to resolution of edema, cognitive status. I think that was really well done. One of the things I noticed is that a lot of these patients presented with visual impairment, and I was just wondering how that improved and if there were any trends over your experience in terms of the number of patients whose vision improved after surgery.
Yeah, that's a very, very good question, and I think something that we maybe lose track of sometimes with olfactory groove meningiomas. There are two ways that olfactory meningiomas can cause vision loss. The most obvious and common is that if they just spill backwards like a plano meningioma and sit on top of the optic nerves, compressing them. And so you're much more likely to get just a loss of visual acuity than a bitemporal hemianopsia, because they're not really necessarily on the chiasm. In fact, the chiasm is the last thing they're going to contact. Secondarily, they can also cause severe papilledema. We have the classic pattern with papilledema in one eye and atrophy in the other, the Foster-Kennedy syndrome. But they can often just cause straight up papilledema, and so from the edema that exists there. So both of those are potential, although I believe that primary compression is far more common. I think this is a potential advantage of this approach, and with that we didn't have any cases of visual compromise, and our visual outcomes stayed steady throughout. So I think that our natural ability and focus on decompressing the optics and not having to manipulate them through this approach held true. Now, in all fairness, I think that probably craniotomy provides very good access to this as well because of the pattern of invasion. But I do think we were able to get to the optics very early, decompress the medial optic nerve along its entire length very early, and open the optic canals early. Those are perhaps one of the few advantages of this approach.
One of my other questions was about, you had mentioned that earlier in your experience, you were staging more of the surgeries. And I was just wondering, were those ones where you were going back and doing a transcranial approach for some of the more lateral extending tumor, or a second stage endoscopic approach? What were the early reasons for staging it? Yeah.
Very good question. It's a really, really astute observation, because that's an important marker in this case series. And the short answer is typically these are two-staged endonasal. Certainly doing an initial debulking and then doing a craniotomy for a very large tumor has a potential advantage of allowing frontal lobe edema to calm down. But what we found also is that a lot of times from these large tumors, when you debulk them, they often billow out away from the olfactory sulcus on either side, and they don't actually have a dural attachment, but rather just billowing out. When they collapse in, you realize the dural attachment's more narrow. That said, the staging here was largely endonasal after endonasal, so 2 stages. And that's a really good example or marker of the learning curve. When you first start doing, or even out to this day, for example, if I do a giant acoustic neuroma, I might stage it, or a huge petroclival tumor. The truth is, there are multiple studies that show as soon as a patient's surgery goes more than 12 hours, they have worse outcomes. And there are a lot of reasons for that. But one of, it can be the length of anesthesia and impact on the patient, risk of DVT. But the truth is, we're all human. You can only function at a high level for a certain period of time until you start to lose your patience, you start to lose your ability. And that's when you have complications, and you don't want the most complicated part of the case, which is usually the brain dissection, to be at, 10 o'clock at night, 8 o'clock at night even. So staging it allows you to break what might be a 12 to 14-hour surgery into maybe an 8 and a 6-hour surgery. And what we would do initially even was, this was before, we had good endoscopic bipolars, and before, we learned to use surgifoam and intracranial and on skull-based surgery. So we might do an initial approach and just achieve hemostasis or coagulate the tumor, and then come back, the next day. And then we got where we could debulk most of the tumor or remove an entire small tumor. And then it got where we, just got better at this because of our technique getting better. Better at it because our tools got better, and better at it because we understood the anatomy and how to avoid things like blood loss, and how to get through certain parts of the tumor better. So it really is a marker of the learning curve and our understanding of the tumor and how to remove it.
My only other question, I did notice that the length of stay decreased throughout the study period, and that's even with more use of lumbar drains, harvesting fascial lata, obviously in a separate incision. So how do you think you were able to counteract those factors and still decrease the length of stay despite those?
Yeah, I think that's probably one very simple thing, and that's the quality of our reconstruction. And also over time, you also have to be careful when you look at any study over a long period of time to say, well, what practice patterns in a hospital might have changed, for example. And fair to say that over 18 years, you're probably going to see a decrease in length of stay of every single tumor, of every single surgery done ever in any hospital in the US at least. So there's some small part of that, but I think it's CSF leak. I think it's our ability to control CSF leak. And, for example, if we got early leaks in some of these patients, or we staged them, that automatically doubles your length of stay. And so I think it's that same learning curve with how to do these and how to effectively get patients through that hospitalization. And look, that's a great point about lumbar drainage, because although yes, lumbar drainage increases your length of stay, because it decreases all these other problems mainly related to CSF leak and meningitis, overall the patient may have a much shorter overall length of stay, and certainly lower 60-day length of stay.
Yeah, and I thought it was particularly impressive, the average age increased over the course of the study period too, and you were still really able to maintain those outcomes. So thank you.
Yeah, wonderful. Thank you so much. And I think on that note, we'll end this podcast. But I just want to take the time to thank everybody for carving out a little space to have this discussion. So appreciate your time, Dr. Gardner and Dr. Zada, and of course, Hayden. Everybody appreciate it. And on closing, we want to mention to all of our listeners on the CNS that this is a CME activity. It's complimentary for all CNS members and worth 1.5 CME. And the podcast is available in our online catalog at cns.org. So thank you again.